Good afternoon, all, and welcome to all the esteemed faculty, speakers, guests, chairpersons, and delegates for this another academic treat led by none other than Dr. Vaishali Chavan, Madam, with Thrissur Obsgynec Society and Palakkad Obsgynec Society. Madam Vaishali Chavan, Madam has been past chairperson Perinatology Committee FOGSI, and now Ma'am is candidate for FOGSI Vice President West Zone. So it's my honor and pleasure to be in this session. So I request Ma'am that we'll just start with the prayer first, and then we'll start the session, Ma'am.
Yes.
Okay. Nandakishore, can we play the prayer? Yeah.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. So I request our President POGS, respected Aarti Nimkar Madam, to
Yes,
give the
Shubhangi,
President
and
address.
yeah.
Yes, ma'am.
Yeah. Now, after 2 weeks, I think we are having this webinar again, and it is with the Thrissur and Society of the Thrissur Gynec Obstetric Society and Palakkad Gynec Obstetric Society. And I welcome Sarina Madam as a guest of honor and Sanju Khud as a guest of honor. That we are having the very much pleasure to have ma'am here in the this webinar from the POJs. And Vaishali is our first speaker, and she's going to speak on the first time in the macrosomia and what are the difficulties in what we have to do in the macrosomia, tips and safe delivery for the macrosomic babies. And for the chairperson, Hema Arya doctor, and Dr. Rashmi from the TOJ Society, and Hema Madam from the Palakkad. And second speaker for the intrapartum care for the joyful motherhood is the Dr. Bindu Menon, and our chairpersons are the Dr. C.V. Chandrika and Kalyani from the Pune also. And we are taking this webinar to reach the different societies of the India and get the promotion for the Vaishali from our POGs, as she is contesting for the VP contest, VP FOGSI. And now we are taking the very innovative programs, and lectures are also very different and on the different topics, which somebody from this for the long time not touch the topics. And one lecture is on the joyful motherhood and intrapartum, postpartum, and everything we are taking in that for the joyful motherhood. And I request our MOC to take this program further.
Thank you so much, ma'am, for your quick introduction for the webinar. I request Dr. Vaishali Chavan, ma'am, to just welcome everyone.
Thank you, Shubhangi. Thank you, Aarti Madam, President POGS. And it's indeed a great honor that we have such esteemed stalwarts and esteemed personalities today who are with their rich experience and expertise are going to enrich the webinar. And we have Dr. Sarina ma'am, who's our guest of honor. Ma'am, it's truly an honor. We have heard you speaking and we've heard your talks, and it's an honor for you to be have your presence here. And Dr. Sanjeev Khurdu is a very own past president from Pune Gynec Society, who's a stalwart and initial researcher in the field of endometriosis, PCOS, and so many infertility related subjects. And Palakkad Society and Thrissur Society. I was just talking with Madam Bindu and Hema ma'am, and Palakkad Society is a new society formed 1 year ago. They were also part of Thistle Society, and they are doing wonderful work. So thank you so much for associating with us, Dr. Hema, Dr. Rashmi, Dr. Bindu ma'am, Dr. Chandrika, and Dr. Kalyani, and Dr. Sandhya and Shubhangi. So Shubhangi, let us proceed ahead. Thank you very much.
Yes, ma'am. Thank you.
That's why, Vaishali, I was wondering how I have not heard about the Palakkad Society.
We are a
It is a
newborn
very,
society.
yeah.
Yes,
It is a
it's
very
like
new,
we
that's
had
why.
Paramati Society, madam. They were
Yeah.
associated with us the same way.
Yeah, we were part of Trishul Society.
Trishul Society, yeah,
Yeah.
like that.
Our own society.
I think Dr. Meenakshi Deshpande madam could not join. So may I request Dr. Vaishali Chavan madam to introduce our guest of honor, Dr. Sarina Gilbaz madam.
Yes, with great pleasure. Can I have madam's formal CV?
Nandakishore, please play the CV slide, please.
Of Dr. Sarina Gilbaz, ma'am. So before they start with the official CV that is displayed, let me tell you, madam, that we are totally in awe of you, and you are here today amongst us to give us your blessings and your wishes, and we are truly honored. So madam is a postgraduate teacher from
Yeah,
1994.
I'm in the webinar.
She
Okay.
has presented,
Webinar.
published many papers. She has organized many conferences, vaginal surgeries on imaging and so on. And she has been president of Thrissur Society in 2003 and 2004. And she was also scientific chairperson for AICOG, which was held in Kochi. She's written many chapters for undergraduates and postgraduates. Madam, we have read your chapters and the amazing publications that you have done. And Madam has received many awards. And Madam has recently, she was president of the Kerala Federation of OBGYN 22-23. Recently attended a concerts conference at Trivandrum of Kerala State Conference, and fantastic academic content and scientific program it was. And Madam is in 2020 also received award for Best Doctor Award by Chamber of Commerce, Thrissur. And many awards, Madam. So we welcome you. And we request you to give us your blessings and say a few words.
Thank you, Vaishali. All the delegates of the Cutting Edge webinar, my co-guest, Dr. Sanjeev Kur, Dr. Aarti Nimkar, the president of the Pune Society, Dr. Meenakshi Deshpande, the general secretary of the Pune Society, and Dr. Amol, who's the clinical secretary of the Pune Society, president of the Palakkad Society, Dr. Hema Warrior, president of the Trishul Society, Dr. Bindu, and the speaker for the day, the convener, Dr. Vaishali Chavan. I wish you all the very best, Dr. Vaishali, for your endurance standing up for the West Side Vice President. I wish you all the very best. All my friends of the Pune Society, the Palakkad Society, and the Trishul Society, I welcome all of you all to this joint webinar organized by Dr. Vaishali Chavan on two very appropriate topics, I should say, often taken for granted, on how to deliver a fecal macrosomic fetus safely, and on the intrapartum care and making prayer delivery a very joyful experience. I think there's a few things we never addressed. We always take it for granted that people know. And I think you've chosen very good topics for this webinar. And with these few words, I wish the webinar all the very best. And all the very best to you, Vaishali.
Thank you, ma'am.
Thank you very much, truly for your blessings and your wishes. And thank you for being with us today. I know you are very busy. Still, you are here with us. Thank you, ma'am.
Thank you so much, ma'am, for your kind words. Dr. Sandhya Mishra, madam is there. We would like to introduce our another guest of honor, Dr. Sanjeev Khut sir. May I have Sanjeev Khut sir's slide, please? Dr. Sandhya, are you there? Nandakishore, please display Dr. Sanjeev Khut sir's slide.
I'm in a webinar.
I think Dr. Sandhya is not there. I'll introduce.
Let me introduce.
Okay, ma'am. Okay, ma'am.
Okay.
Yes, thank you so much.
Because it's
Yes,
a great honor for me to talk about Khut sir, whom we look up to, and sir is an inspiration, motivation for us here at Pune Gynec Society. And sir encourages us all the time and really advises us. Sir, in spite of very busy OPD, you're here with us. And Sir has established Pune's first super specialty infertility center. And Sir has always been highly academic. He was gold medalist at MD. He was awarded Foxy Young Scientist Award by Foxy. And this was at Singapore and Bali in Indonesia. And like I mentioned earlier, Sir has done amazing original research work, and the Padmasan position for LabTL. He invented Kurz clamp. He also is known for his Kurz technique of tubal ligation device, which is used for reversal of reversal and tubal recanalization. Kurz peritoneal jelly, it's a new sign for pelvic endometriosis, and Kurz spotted deer sign, a new diagnostic sign for PCOS. Sir has great many scientific contributions and presentation and awards at national and international conferences, and many books and chapters that he has written. Along with Sadhna Madam, he has also authored a book on polycystic. So thank you, sir, and thank you for being with us today, and thank you always for your encouragement to us.
Thank you, dear Vaishali. It's a real pleasure being here with you in this webinar, and my best wishes. In fact, I have seen Dr. Vaishali right from the day she entered Pune Gynec Society, and I know besides being brilliant, she has been so hardworking and innovative, and she has given so much to Foxy. So I wish you all the best for the office of the Vice President. Thank you so much. It's real. Well, blessings are all with you, Vaishali.
Thank you. Sir.
And thank you for organizing. Yes. And thank you for organizing this wonderful webinar, especially getting our POJs along with Thrissur and Palakkad. So, you know, the thing is, so the knowledge that you are going to spread is going to spread to far corners of India. And I'm very happy that you have chosen, like Madam had already said, topics which are really less touched or less talked about. But these are very, very relevant for a practicing obstetrician. And I'm sure you as a speaker and following you, the other speaker is going to give us a lot of good messages, take-home messages for us to practice. So thank you very much, and God bless you.
Thank you, sir, for your blessings, sir, and for your wishes. And like I said, sir has always been encouraging us, and it is because of sir's encouragement that I entered Pune Obstetric Gynec Society and Foxy. So, sir, thank you very much for always being there for us. Thank you again.
My best wishes, special. Yes.
Thank you so much, sir. Now we shall look forward to the most awaited session. The speaker for that is Dr. Vaishali Chavan, Madam, and the topic is macrosomia tips for safe delivery. So I'll just introduce the chairperson for first session, Dr. Hema Warrior, Madam, and Dr. Resmi CR, Madam. Can we have Dr. Hema, Madam's CV, please? Dr. Sandha, Madam, had joined, I think so. Ma'am, I request you to introduce Dr. Hema, Madam. Nandakishore, please, can we have Dr. Hema, Madam's slide, please?
Yeah, okay. So, good afternoon, everyone. I have the proud privilege to introduce Dr. Hema Warrior. So, she has done her graduation from the prestigious Armed Forces Medical College, Pune, and her post-graduation from Calicut Medical College. She has done a diploma in laparoscopic surgery, Kiel, Germany, and she is trained in ultrasound. Currently working as consultant OBGYN and laparoscopic surgeon at District Cooperative Hospital, Palakkad, and Mediterranean Hospital, Palakkad. Welcome, Madam. Can we have the CV of Dr. Reshmi, Madam? Mr. Nandakishore.
The next slide, please. Mr. Nandakishore, the next slide, the very next slide to Hema ma'am's CV.
Okay, so our next chairperson is Dr. Reshmi CR. She is a professor at OBG GMC Thrissur, Secretary of TOGS, Secretary of RCOG Kerala Chapter 2325, MRCOG Part 3 Examiner, Medical Education Unit Coordinator GMC Thrissur, KUHS Board of Studies member, PG Surgical Nodal Officer, MNM Review Kerala, National Mentor for Lakshya and member of NQOCN, faculty at the KUHS certificate courses. She's a peer reviewer of Jogi and BMJ Open Quality and scientific committee coordinator for TOJS 2020 to 22 and editor of TOJS Journal 2015-2017. She's received the gold medal for best outgoing PG student in 2002 GMC Calicut. Her areas of interest include quality improvement in healthcare and high risk obstetrics. Welcome, madam. So now I request Shubhangi to take over.
Yes, okay, ma'am. Now we'll move towards our first session. Speaker Dr. Vaishali Chavan, madam. I request Dr. Hema Warrior, madam, to introduce Dr. Vaishali Chavan, ma'am, please. Nandakishore, can we have Vaishali, ma'am, CV? Thank you.
Good afternoon, everyone. Thank you for the kind introduction, Dr. Sandhya. It's a pleasure and privilege to introduce Dr. Vaishali Chavan to this prestigious CME. So, Dr. Vaishali Chavan is the clinical director of Cloud9 Hospital, Kalyani Nagar, Pune. He's the director of Sanvi Clinic Women's Health Center. He's the vice president elect of Pune OBGYN Society. He's the chairperson of Perinatology Committee, FOGSI, 18 to 20. And she has various publications to her credit, contributions to many FOGSI focus and chapters in international publications. And she has won many accolades. She was judged the Inspiring Gynecologist of West India by the Times Group, Health Champions FOGSI by the FOGSI Society, Legends of Gynecology Award by FOGSI in 2024, Lokmat Award for Excellence in Medical Field, and several other awards. And for excellence in social work, not only academic work, but also for social work. And I understand that she is also standing for the position of Vice President West Zone FOGSI. I wish her the very best. Can we start the session, Dr. Vaishali?
Yeah. Thank you, Hema ma'am, for your wishes and your very kind introduction. And it's truly an honor for me that you will be chairing the talk which I'm giving yourself and Dr. Reshmi. So I would just like to share my screen and just a minute. Yeah, is my screen visible?
Yeah.
Yeah, so I'm
Yes,
going to
Shubhangi,
talk
go
about,
ahead.
yes.
Vaishali, go ahead.
Yes, ma'am. Thank you, ma'am. So my talk is fetal macrosomia and the tips to avoid complications during delivery. So what is exactly macrosomia? How do you define it? So this is actually macrosomia means a large for gestational age, implies a birth weight equal to or more than 90th percentile or absolute weight which is more than 4 kg or 4.5 kg, regardless of whatever gestational age, or on ultrasound if the abdominal circumference is more than 95 percentile. Now, today itself, I had a patient whom I had to post for section, and I had written indication. Apart from she has pregnancy cholestasis, severe preeclamp, GDM uncontrolled, and macrosomia. So she Googled and she asked me, why have you written macrosomia? My baby weight is less than 4 kg. And as per definition, if the baby weight is more than 4 kg, then only you can label as macrosomia. So nowadays, patients do Google, and the definition that is given of 4 kg actually applies for the Western population. Indian women are smaller and our babies are smaller. So even baby who's about more than 3.5 kg can also fall under the category of macrosomia. And second thing, this particular patient of mine who was referred from outside, and her abdominal circumference was, baby's abdominal circumference was more than 98th percentile. So as per definition, if the abdominal circumference is more than 95th percentile, then yes, it is macrosomia. And then nowadays patients know all these things, And when you explain to them, counsel them, hopefully, thankfully, they listen to us. So is there any way that we can predict like big baby and baby, if she's allowed to deliver normally, baby may end up with shoulder dystocia? Are there any prediction methods? Because many a times we deliver big babies, nothing happens, there's no dystocia, and patient just progresses and there are good contraction, the cervical dilatation, and even a 4 kg comes out very easily. So what is it? How do we predict that, yes, this baby is going to have shoulder dystocia? So it is actually the difference in the abdominal circumference and the bipyramidal diameter. And if it is more than 2.6 centimeter, then yes, there could be shoulder dystocia. Now, there are various factors for macrosomia. Could be diabetes, GDM, or could be postpartum pregnancy, excessive maternal weight gain, maternal age more than 30, or maternal obesity, and so on. And the outcome can be quite critical. There could be shoulder dystocia, brachial plexus injury, perinatal death, hypoxic ischemic encephalopathy, and there could be PPH, more indication for cesarean, or even perineal tears, 3rd degree, 4th degree perineal tears. And the damage to the baby is more, especially if there's fracture of clavicle or brachial plexus injuries leading to Erb's palsies and so on. Usually, Erb's palsy, brachial plexus injuries, they resolve by the age of 1 in most of the cases, in 80 to 90% of cases. These big macrosomic babies later on may have lifelong metabolic diseases. So when a patient is in labor, you need to assess, and while the patient is in labor, you can actually predict that yes, there could be a chance of shoulder dystocia when there is a arrest of descent in the 2nd stage or prolonged 2nd stage of labor. And if you feel, you can always take a second opinion, a senior obstetrician's view. So prolonged 1st and 2nd stage of labor are common when macrosomia is present. And then comes the thought that if it's a big baby, should we do induction of labor before 39 weeks and, not allow the baby to grow further and then deliver the baby? And regarding this, the NICE guidelines do not support this, that induction before 39 weeks for macrosomia. But there is something known as SDM, that is shared decision making, where you can counsel your patient and together we can plan on timing of the birth to prevent shoulder dystocia. So what exactly is shoulder dystocia and how does it happen? What really happens is the failure of the shoulders to deliver after delivery of the head within 60 seconds. So the head delivers out. Because it's a big baby, the biacromial diameter is big. What happens is the shoulder of the baby goes and impacts here below the pubic symphysis, and this is a bony bone, and here it is impacted, and the impaction of the shoulder in this way causes injury here to the brachial plexus, and this is shoulder dystocia. So head comes out and the shoulders get impacted, and it's difficult to dislodge and remove. And if this happens for more than 60 seconds, then it is shoulder dystocia. So by definition, it means that prolongation of head to body delivery more than 60 seconds has been said to be a shoulder dystocia, and there's lot of maternal morbidity and perineal tears and brachial plexus injuries. How do you diagnose? There's a typical turtle sign, and if you see a turtle sign like this, you can really feel that panic setting in, that, oh no, this looks like shoulder dystocia. So what happens is the head comes out and the anterior shoulder gets trapped beneath the pubic bone. And with every contraction, what happens is the head gets pushed out. So with the uterine contraction, the head gets pushed out. And when the contraction subsides, again the head comes back to its original position. So this is turtle sign. Now this is an animated picture and it looks very clean. But what happens in real life is this kind of situation, and a horrifying experience. And the head is stuck, and there's panic everywhere, and patient is screaming, and the obstetrician is agitated and panicking, and this is not a good scenario when it happens in labor room. But the positive thing is, if you know the correct maneuvers, then this problem can be solved immediately. So what are the simple maneuvers which can help us deliver this baby stuck like this? First of all, you need to call for help, because these maneuvers cannot be done by you alone or by your one single assistant alone. So whoever is there in labor room, the maushis, the staff, the nursing staff, the student staff, whoever is there, just call them, because you're going to need help. Do not push, do not give more fundal, do not try to pull the baby's head out. Clean the area, drain the bladder, give adequate episiotomy. Episiotomy is not going to open up the bony bones, which, that small space is not going to open up. But it is good for the maneuvers that we are going to plan. And then you should also keep an anesthetist, pediatrician. Everybody should be on alert. Drain the bladder, and then take the patient to the edge of the table, and then McRoberts position. We all of us know what it is. It simply means hyperflexion and abduction of hips. The hips are hyperflexed and abducted. At the same time, somebody has to give a suprapubic pressure. So suprapubic pressure is to be given in which way? It is given to be given in such a way that the anterior shoulder, which is impacted below the bone, gets pushed inside the inlet. So that is why you need two people to hold the patient's legs, and a third person, or maybe probably the same people, to give the suprapubic pressure in such a way that the anterior shoulder, which is impacted, gets dislodged. When you give McRoberts position, what happens? It reduces the lumbar lordosis, and also it creates more space by pelvic tilt, and it helps in the facilitation of the shoulder delivery. So this is how it is done. And that is the reason you can see two people on either side holding the legs, hyperflexion and then abduction. And suprapubic pressure, when it is given, when hip flexion is done, it flattens the lumbar lordosis, and it opens, creates more space, and then baby is delivered. By this simple maneuver, almost 90% of the 80 to 90% of shoulder dystocia gets reduced, and every step needs to be done for not more than 30 to 60 seconds. Now there's Rubens 1 and Rubens 2. Rubens 1 is to push the anterior shoulder to oblique diameter from outside abdominally, and Rubens 2 is again per vaginally. You try to push the anterior shoulder to oblique by doing per vaginal examination. Then coming to Wood's corkscrew maneuver. So these are all the maneuvers which are to dislodge the anteriorly posteriorly impacted shoulder and turn it oblique and then deliver out. So these are the various maneuvers which just shifts the shoulder and delivers the baby. So Wood's corkscrew maneuver, you can see Rubens maneuver, Wood's corkscrew maneuver, all of them, the principle is the same, to dislodge the impacted shoulder. So in Wood's corkscrew maneuver, what is done? Corkscrew, is turning around. The right hand is applied to the back of the anterior shoulder, and the left hand is applied in front of the posterior shoulder, and the baby is flipped like this, rotated, and when it is rotated, the anterior posterior diameter becomes oblique, and baby is delivered very easily. The same way it can be done, the principle behind is the same. In this position, pressure applied alternatively to the shoulders, anterior posterior is made into oblique, and then baby is delivered out. So these are the various maneuvers. There's another maneuver which posterior arm, And the posterior arm is you do a pervaginal examination, and you sweep the posterior arm anteriorly across the baby's chest and pull it out. Once one arm is pulled out, automatically the diameter reduces and the baby is delivered. And there's something known as Zavanelli procedure, in which you have realized that no, baby just cannot come out. So what you do is that baby is pushed completely inside. So the fetus which is trapped is pushed, rotated and pushed inside. The head is pushed in back. And once the head is pushed in back, immediately emergency cesarean is done. That is Zavanelli procedure. There's a shoulder shrug technique. When we shrug our shoulders, the diameter reduces. The same way, both the shoulders of the baby are shrugged like this, pulled up, and then delivered. There's Gaskin's technique, where the mother is on all four, and when in this position, the diameter can increase by as much as 1 to 2 centimeters. The anterior posterior diameter can increase, and this is a very interesting Gaskin's maneuver, where the mother is put on all fours and then the delivery happens. They say gravity also helps the baby to come down, and fetal weight against the pubic bones stretches the pelvic ligament, and the pelvic outlet increases, and the baby comes out easily. So Gaskin's maneuver is also something which can be tried, and they have said that it gives good results. So these are few maneuvers, and should be knowing all these maneuvers. And it is important that drills should be conducted in your hospital, and everybody should be taught. Whoever is working in the labor room should know about these maneuvers. And drill for shoulder dystocia, very important. And there's a mnemonic helper, that is H, call for help, E, evaluate for episiotomy, L, legs, that is macrobursts, that is you hyperflex and abducts. P is external pressure, that is suprapubic pressure, in such a way that the anterior shoulder comes inside the pelvic inlet. E is various rotational maneuvers. We saw various corkscrew maneuver and so on. R is remove the posterior arm, and R is roll the patient to her hands and knees. So suspected fetal macrosomia is not really a contraindication for vaginal birth, but you should be prepared that in case there is dystocia, you should be ready to do all these maneuvers, and there should be experienced obstetrician, neonatologist, anesthetist around. And of course, prevention is the key, and antenatal period, prenatally, patients should be advised to have low glycemic index, exercise, pre-pregnancy. For severely obese patients, even bariatric surgery is recommended. With this, I would like to thank all of you for patient hearing, and I seek your blessings and support for the post of Vice President FOGSI West Zone. Thank you very much. I'll stop sharing. Yeah.
Thank you so much for, hello.
Yes, yes.
Thank you so much, ma'am, for your wonderful session. I will just request Resmi madam to conclude the session.
Yes, thank you, Dr. Shubhangi and Dr. Vaishali Chauhan, and all the chairperson, Dr. Hema ma'am, and all the other senior faculties. It is indeed an honor to chair the session. Dr. Vaishali, an excellent presentation of how to deal with macrosomia and shoulder dystocia. And yes, you have correctly said, in our patients, more than 4 kg may not be macrosomia's correct criteria. For us, the smaller patients, that we have to look at the patient and then decide if the baby is big. And also always anticipate shoulder dystocia, even though 50% of shoulder dystocias occur not in macrosomia but in normal size babies, and 50% of macrosomias, and more than 50% of macrosomic babies may not develop a shoulder dystocia. And you have excellently covered the helper manual, all the manuals, and it is very, very important that we have drills, periodic drills, not just once a year. You have to have drills, periodic training, and then make them remember again and again how to conduct, what to do when there is shoulder dystocia. The call for help is the most important. And also, I would also like to stress upon the posterior axillary sling traction. So that is something which is the past, which is said to be a very useful and very effective maneuver, which can bring out the posterior arm and effectively deliver out, especially especially when it is unilateral. And always remember, bilateral shoulder dystocia, you have to go for a 7LE, because bilateral shoulder dystocia, it is not possible to, all these maneuvers may not help you, and you have to go for a replacement of head and doing a abdominal delivery of the baby. Thank you so much. Okay.
Thank you, Dr. Rashmi. You have
Thank you.
so beautifully, summarized everything and given us more inputs from your side. And so rightly said, periodic drills are so very essential that everybody learns about these, and simple maneuvers help. So thank you so much. Anything, Hema ma'am, Khur sir is also here. Serena ma'am, can you please give your comments?
Hema
Ma'am,
madam is not audible.
you're mute.
I would stress the past, that is the posterior arm sling traction. That is a very useful maneuver. I think it should be taught to all the juniors. It is doable. Most of us think that it is not doable, but it is actually. So that is one maneuver that we need to taught to all the juniors.
Yes, madam, that is very correct, because past is actually, when you do, it is actually doable. And
Sorry, you are on mute, sir.
The wonderful animation that you showed really made me understand. See, once upon a time, we learned all these things, but then being away from obstetrics, honestly, this was a big learning lesson for me personally. And the animations really helped me to understand every step that you took. Excellent, really. Wonderful talk. Really enjoyed.
Thank you, sir. Thank you, sir. Thank you so much, sir.
Thank you so much, Vaishali ma'am. As like truly said by such a senior person, Sanjeev Khut sir, if he's saying that he has learned so many things from the session, we are very much a kid, and like it was so much information for us. Thank you so much, ma'am, for the wonderful session. And now we have another interesting topic, which is uncommon and like less touched. We'll move towards our second session. The topic is intrapartum care for joyful motherhood, led by Dr. Bindu Menon, madam. Speakers for the session the chairpersons for the session is Dr. Chandrika madam and Dr. Kalyani Ingai madam. I will like to introduce Chandrika madam. Can we have her CV, madam CV? Nanda Kishore, can we have madam CD? Yeah. Good afternoon, madam. It's an honor to introduce such a senior person. Madam is a retired professor and HOD from Government Medical College, Thrissur. She is currently working as professor and HOD at Government Medical College, Palakkad, Kerala. Madam is having 43 years of teaching experience. She has been past president of Thrissur Obs-Gynaec Society, and also Madam has been past president KGMCTA, that is Kerala Government Medical College Teachers Association, Thrissur. Welcome, ma'am, for the webinar.
Thank you. Thank you. Thank you so much for the nice introduction. And I am very happy that you invited me on this occasion, and that too very specific and very beautiful subject, which we should know what to do during labor, and how to manage, and how to make it, how we can give relief for the patient as well as the obstetrician. Thank you so much for the nice introduction.
Thank you, ma'am. Can we have a CV of Dr. Kalyani Ingre, madam, who is the second chairperson for the session 2? Welcome, madam. Dr. Kalyani Ingre, madam. She is director and clinical consultant and chief embryologist at Nirmiti Clinic, a center for assisted reproduction and endoscopy, Chinswad, Pune. Madam is also consultant at Aditya Birla Memorial Hospital, Oyster and Pearl Hospital, Surya Mother and Child Care Super Speciality Hospital, Pune. Madam has been treasurer POGS in the year 2014 and 15, vitrification specialist training at NHS Singapore. Madam has been member of medical abortion and contraception committee in 2010-11. Madam has also been the faculty of Fogsy Adolescent Health Committee in 2013-15. Madam has written chapter on fibroid and infertility in the book Fibroids as a co-author. So, and Madam has also been co-author in use of GCSF in thin endometrium in the book Novel Approach at 6th COGI World Congress at Vietnam in November 2014. A research study as poster presentation. I welcome Madam for the webinar.
Thank you. Thank you so much for the kind introduction. It is very nice to be here in the panel of all the stalwarts of obstetrics. I thank Vaishali personally to give me this opportunity. And I wish her all the best for her further journey as the Vice President of Fogsy. So I'm very, very happy to be here and learn more from all the seniors and professors. Thank you.
Thank you, ma'am. Kalyani, madam, may I request you to introduce our speaker for the second session, Dr. Bindu Menon, madam.
Yes. It is my privilege to introduce Dr. Bindu Menon. She is the professor and unit chief at Jubilee Mission Medical College at Thrissur, Kerala. She is the president TOGS, past treasurer of the Kerala Federation Obstetrics and Gynecology. She is the past chairperson of EMOCALS, that is Emergency Obstetric Care and Life Support of Kerala. She is the past scientific committee chairperson of TOGS, Thrissur Obstetrics and Gynecological Society of Kerala. And her areas of interest, as definitely we are going to witness it now, high-risk obstetrics and general gynecology. So basically, Madam is going to enlighten us today on a very important topic of intrapartum care for the joyful motherhood, whereas the intrapartum is always a dreaded situation for any woman who's going to undergo labor, and they're always worried about how it is going to be. So, Madam, please let us know what all good things we can do for the would-be mothers and make this journey joyful and comfortable. Over to you, madam.
Thank you, ma'am, Kalyani ma'am, for the kind words. And I am very happy to be a part of this Pune Obstetric and Gynecological Society, CME. And thank you, Dr. Vaishali and Dr. Shubhangi, for the kind invitation. And wish you all the best, Dr. Vaishali, for the post for the Vice President, Westward. So today I'm going to talk about the intrapartum care for a joyful motherhood. So preparing the patient for labor and delivery usually starts from the antenatal period. Antenatal classes helps to reduce the anxiety a lot in the patient and in her relatives. All women should have a positive childbirth experience. All should have access to respectful maternity care. That is very important. Assure them regarding privacy, adequate pain relief, and companion during labor. And there should be a shared decision making. So we cannot decide anything on the patient. It should be we have to discuss everything with the patient. Then it should be a shared decision making. So how can we monitor the patient in the first stage of labor? The first stage of the labor starts from the regular uterine contractions to full dilatation of the cervix. When the patient comes to the labor room, receive the patient to the labor room with a smile. Treat all women entering the labor room with dignity, kindness, and respect. Reassure and make her comfortable in the labor room. So when we have to admit the patient in the labor room, when the patient is having regular uterine contractions, painful uterine contractions, and on per-vaginal examination, if the cervical effacement is more than 80% and the cervical dilatation more than 4 centimeter, then we can say the patient is in active phase of labor. WHO says nowadays it's the active phase of labor starts from 5 centimeter. So then only we have to keep the patient in the labor room. So before 4 centimeter dilatation, or according to the WHO 5 centimeter dilatation, patient can, that is called as a latent period of labor, that we should not keep the patient in the labor room that stage. How we can manage the first stage of labor? So when the patient comes to the labor room, initial examination has to be done, the vitals of the pulse, BP, temperature, and we have to assess the uterine contraction to see whether it's coming in regular intervals and monitor, and thereafter pulse rate and the fetal heart rate should be monitored every half an hourly. The blood pressure, temperature, and respiratory rate of the patient should be monitored every 4th hourly. And we have to review the antenatal records to see whether the patient or the baby is having, fetus is having any high risk factors earlier, or there is new emergence of the any high risk factors. Evaluate the fetal status on admission by an admission CTG or NST. Confirm the patient is in active labor by doing a per-vaginal examination. So this phase, I told you, before the 4 centimeter dilatation, that is the latent phase, that is nowhere nowadays there is latent phase in the partogram. So during up to 4 centimeter dilatation, we can encourage the patient to walk around, ask her about the hydration, she can take fluids or the soft diet. You can advise them to have the breathing exercise, yoga, to decrease the anxiety. Address anxiety of the couple and reassure them. So this is the initial. So you can tell them it's initial phase of the labor. It will take some more time. You can be with the relatives and the friends. Now coming to the active phase of labor. So the active phase starts from the 4 centimeter dilatation. And the duration of the active phase, it can be up to 12 hours in a primigravida and up to 10 hours in the multigravida. So during this time, we can allow clear fluids to the patient. So preferably some soft diet also, preferably clear fluids. And why we are insisting on the clear fluids, if the patient can't take any oral fluids, we have to give IV fluids. That is because hydration prevents hypovolemia, and thereby, if there is hypovolemia, there can be decreased uteroplacental circulation and fetus can be affected by the fetal distress. And we have to advise on the, suggest on the position, maternal position. Patient can use any position which is comfortable for her. So try to avoid the supine position. Whenever there is patient is lying in the supine position for a long time, it can produce vena cava compression and again decrease uteroplacental circulation and thereby fetal distress. So it can be anything. So the squatting position or the birthing ball or anything. Patient want to walk around, standing, anything she can use. That is her choice. And we have to offer any analgesics of the choice. It can be anything, whichever is the your choice in whichever hospital. So you can offer opioid analgesics, fentanyl, or the pethidine, Entanox, that is an inhalational analgesia. It's a combination of 50% oxygen and 50% nitrous oxide. So the problem is whenever you are using the Entanox, try to keep the hold the patient has to hold the Entanox by herself. The mask she has to hold. No relative or the bystander has to hold the mask. Otherwise, if the bystander is holding the mask, more amount of the Entanox will go into the lungs of the, it can produce unconsciousness. So usually it will, when the patient gets pain, she can start inhaling the Entanox, and once so she will go into some sedation. by the time. So that is why the patient has to, that is very important. You have to advise a patient only has to hold the Enterox max. And the ideal and preferred one is the epidural analgesia. If facilities are there, that is the best. Epidural analgesia gives the, nowadays the walking epidural is also there. It will prevent the motor blockade. And another most important thing is the continuous support in labor is very essential. That is by a birth companion. So it can be her husband, partner, friend, or the any other relative. As I told you, we have to keep the oral fluids, clear fluids. If the along with that, you can combine if the patient is not taking normal saline or the ringer lactate at the rate of 125 ml per hour. We have to hydrate the patient well. And to prevent infection in the first stage of labor, routinely no antibiotics are advised. If there is a prolonged labor after ARM, that is 18 hours, we can use the first generation, that is the preferable first generation cephalosporins, that is the cefazolin. If it is not, it's the availability is very less of the cefazolin, then we can use the second generation cefuroxime. That is the antibiotics, no routine antibiotics. So before touching the patient, before doing any pervaginal examination, we have to use, and before catheterization also, we should be very careful, and we have to be very careful about the aseptic precautions. Always use a dedicated sterile PV tray for each and every patient. We cannot take from a mixed the sterile gloves we have to take. And we can use the chlorhexidine hand rub between the patients before touching and after touching the patient. We have to use. This is the dedicated PV tray. You have to pour the chlorhexidine before cleaning. And you can use the sterile gloves also. This is what we are having in our hospital. Each and every patient, we are just autoclave dedicated PV sets are available. So another important message what we have to do in the active phase, that is when the patient is getting good uterine contraction and the patient is progressing more than 4 centimeter, don't use prostaglandins in established labor. That is no role for, again, the misoprostol or the Serviprime, that is the dinoprostone gel. It can produce the tachysystole and the hyperstimulation. So there is, don't use prostaglandins for the augmentation of labor. It's only for the injection. So don't use in established labor. And oxytocin has to be used as a infusion pump or the syringe pump. Don't use with the IV line, because if you are using with the IV set, if the hand is bending at the wrist, we are starting the IV line, the flow rate can be changed. So always use oxytocin with an infusion pump or the syringe pump. That is ideal. And when the patient is in active labor, that is more than 4 centimeter, you can do the ARM. So that will further augment the labor. So, but we have to avoid ARM if the patient is having HIV, HPSHE, or the HCV positive. Oxytocin augmentation can be done only after 1 hour of ARM. That is also very, very important. Don't immediately start oxytocin soon after the ARM. So it can produce again vigorous contraction, and we have seen more of the amniotic fluid embolism and the death due to amniotic fluid embolism. If you are starting oxytocin soon after ARM, and if you are using prostaglandins in established labor for the augmentation. So during the active phase of labor, when the patient is in the labor room, we have to monitor the fetal heart sounds for 1 minute soon after the contraction. So in the first stage of labor, every 15 minutes, we have to check for the fetal heart sounds for 1 minute. And in the second stage, either after each and every contraction or every 5 minutes, we have to check the fetal heart sounds for 1 minute. So whenever you are checking for the fetal heart sounds, always check the maternal pulse also, because we should not be confused with the maternal pulse. And that is also very important whenever you are monitoring with the continuous CTG. Always make sure it's not recording the maternal pulse. So again, we have to do the 4th hourly PV to monitor the progress of labor in the active phase of labor. And it has to be plotted in the partogram and watch for increased contraction, that is more than 6 contractions in 10 minutes, that is tachysystole, and the fetal distress. And one more thing we are following is the no antispasmodics like Proctavarin or the injection Buscopan in the active phase of labor. Once the patient reaches the active phase of labor, that means more than 4 centimeters, automatically she will progress. So we don't have to augment with Proctavarin or Buscopan. Again, here, when you are combining this smooth antispasmodic, that is Proctavarin and Buscopan, and we are using the misoprostol for the injection of labor, we have seen the uterus becomes, especially the lower segment of the uterus can become very soft, and it can lead to lower segment PPH. And we had patients with the lower segment PPH and again maternal mortality due to PPH So in Kerala, we have stopped using the injection and Buscopan for augmenting the labor in active phase of labor. So how to assess the labor progress when she is in active phase? We can do the digital examination PV that I told you. On admission, we have to do the pervaginal examination, then 4th hourly, and then we have to do the other examination when you are offering analgesics or the epidural analgesia, or when the patient is having an urge to push, or when the fetal heart rate is abnormal, to rule out any cord prolapse, anything. So you have to do. These are the indications for doing pervaginal examination. And the other method of assessing the labor progress is with the help of the partogram. I will explain you what we are using, which partogram we are using. Another nowadays, the recent thing is the transperineal ultrasound. So we can assess the descent of the fetal head with a transperineal ultrasound. Partogram is a graphic representation of the events of the labor. All the events of the labor and the monitoring of the fetus and the mother, it can be seen in a single sheet of paper. So that is very useful. We don't have to turn the pages one after another. So any right deviation that suggests a protracted or the arrest disorders. On the left side, you can see the WHO modified partogram. So in that one, that active phase starts from the 4 centimeter dilatation. It has got an alert line and an action line. There is no, you have to notice, there is no latent phase in the partogram, modified partogram. On the right side, you can see that is the WHO labor care gate, that is labor care gate, that also I will explain you in detail. So what we are till now we learned in the partogram, when the patient reaches the active phase of labor, that is after 4 centimeter, most of the average rate of dilatation in both primaries and multis is at the rate of 1 centimeter per hour. So, but in reality, not all women progress in the labor uniformly. That means not all patients, if you take 100 patients, all the 100 patients won't progress at the rate of 1 centimeter per hour. Some women will take longer time, but it is absolutely normal for both the mother and baby. So to give little more time, if it progress, if it takes more than 1 centimeter per hour to dilate, we don't have to rush to augment or to take the patient for cesarean section if there is a delay in the cervical dilatation of more than, if the patient takes more than 1 hour for dilating 1 centimeter. So this is the WHO in 2018 revised the partogram based on the revised global recommendations on intrapartum care. That is known as the WHO Next Generation Partogram. That is a revolutionary step towards individualized labor care. It was published in BJOG in 2021. So this next generation partogram, we are giving more importance to the individual care of the. So there is a new understanding of the individual variability of the progress of labor, and there is a global shift towards positive childbirth experience. That is very, very important. So need for a new labor monitoring tool is recognized. So this is the WHO labor care gate. So what are the principal aims of the labor care gate? How it different from the normal partogram? So this offers labor care gate. It offers supportive and evidence-based care throughout the labor. monitoring and documentation of the well-being of the women and babies. It monitors the progress of labor and identify emerging labor complications to trigger reflection and specific action for the abnormal observation. If there is any abnormal observation, so that moment we have to take care to stimulate this shared decision making, that is women-centered care, and support the audit and quality of improvement of labor management. These are the main principal aims of the labor care. So all together we can make a positive childbirth experience. How it is different from the modified old partogram and the new labor care. In the old modified WHO old part, whatever we are using till now, the active phase starts from 4 centimeter. In the WHO labor care, active phase starts from the 5 centimeter. So in the old one, the fixed 1 centimeter per hour is for the alert and action line. In the new labor care gate, there is no alert line, no action line. So there is evidence-based dynamic time limit for each and every cervical dilatation centimeter. And there is no recording of the strength of contraction in the new one, and old one, there is no second stage monitoring. So, but in the labor care gate, there is intensified monitoring of the second stage of the labor. That is also very, very important. Once the patient is fully dilated, we cannot assure the patient will deliver by Chandi. There can be arrest of descent, and all these things can happen. So intensified second stage monitoring is included in the new labor care gate. No recording of the supportive care in the old one. Detailed recording of the companion in labor is very, very important. And there is emphasis on the restful maternity care, and the labor analgesia is also very much included in the new labor care. That is the main difference in the one. So it has got, just like a old partogram, it also has got many divisions: the general information about the patient, supportive care, care of the baby, labor progress, medication, and the last we have to take, depending upon all these things, there is a progress medication. We have to take a shared decision making after discussing with the laboring woman. So this is the new labor care kit. There are the alert things are the. So this column alert, this red mark in red are the alert. If it processes that one, if it is not there, if the companion is not there, if there is no labor analgesia, we have to mark in red. So all the things alert has to be marked in red round. The round we have to mark. So that is by individualized care. So these are the alert value. Old one, I told you, the cervix has to dilate at the rate of 1 centimeter per hour. So here in the new one, it's the 5 centimeter. There can be, if the patient is 5 centimeter dilator, we can allow plus or minus 6 hours. That 5 centimeter patient can be in the, and the 6 centimeter dilated plus or minus 5 hours, we can allow that patient. 7 centimeter means plus or minus 3 hours, like that. We can allow little more time, not the 1 centimeter per hour. And in the second stage, we can give 3 hours equal to or more than 3 hours for a primary patient, or 2 hours, minimum 2 hours for a multi-patient for the second stage duration. So this is the, what is the rationale? Why there is alert lines in each centimeter of dilatation? Evidence-based time limit for each centimeter of dilatation, derived from the 95th centile of labor duration at different centimeter levels in women with normal perinatal outcome. So that is not going to, so we don't have to be very strict. 1 centimeter per hour, the patient has to dilate, and we have to intervene if the patient is not progressing. That means the protracted active phase is we can wait, and if the mother's condition is okay, the fetal condition is okay, we can wait and watch. That is the importance of the labor care. When we can say there is a delay, that means the patient is, for the primaries and multis, if the cervix is not dilating, the dilatation is less than 2 centimeter in 4 hours, we can say there is a delay in the active phase or the protracted active phase. That means one PV to other PV, there is less than 2 centimeter dilatation in 4 hours. What is arrest disorders? Arrest of dilatation is for primies and multis if there is no progress in the dilatation for more than 2 hours. So the patient was 5 centimeter 4 hours prior, and after 4 hours also she is 5 centimeter. That is the arrest of dilatation. So the management, so whenever there is an arrest of dilatation, check for the contraction whether it's adequate or not, and it has to be reassessed by a senior obstetrician. And the another thing is the arrest of descent for the more than 1 hour. The head is not descending for more than 1 hour. Then the same management, that check for the contractions and reassessment by a senior obstetrician. Arrest of labor should not be diagnosed before 6 centimeter. That is also very, very important. I have given the example of 5 centimeter. That is not correct. So arrest of labor should not be diagnosed before 6 centimeter. Only after 6 centimeter dilatation, we can say the arrest of dilatation of the labor. So the causes of arrest are the cephalopelvic disproportion, malpositions like occipito-posterior, malpresentations like Brough, inadequate or the incoordinate uterine activity. So whenever we are monitoring the fetus by the continuous ETG monitoring or the intermittent auscultation, we do find sometimes a single prolonged deceleration during the fetal heart rate monitoring. Whenever that is single prolonged deceleration, that means if the deceleration lasts for more than, that is acute bradycardia more than 3 minutes, is the prolonged deceleration. So we have to rule out acute events like cord prolapse, abruption, or the rupture uterus. Other causes of the prolonged deceleration can be tachysystole, that is frequent contraction, maternal hypotension secondary to epidural analgesia, or the supine hypotension syndrome. So immediately the management, whenever the prolonged deceleration persists, and if there is a cord prolapse, a rupture, or the abruption, immediate delivery with the fastest route possible we have to do. So immediate delivery, cord prolapse, if the patient is fully dilated, we can deliver by the instrumented delivery. Or if not fully dilated, take for cesarean. Abruption, fully dilated, complete the delivery with the instrumentation, or the otherwise take for the. So that is, in the absence of acute events and the prolonged deceleration persists, we have to do the intrauterine resuscitation. So what are the intrauterine? What is intrauterine? If the patient is on oxytocin, stop the oxytocin. Give the uterine relaxants like butalin or the nitroglycerin spray, and the patient is having hypovolemia, suspecting hypovolemia, hypotension, give IV fluids and left lateral position. That means the change of position, and oxygen by mask. Some people are saying the oxygen is not a very effective. Even with this intrauterine resuscitation, the bradycardia is the prolonged deceleration is not recovering. So we have to do apply the 3 minutes rule. That is, the 3 minutes rule is the 3 minutes call for help. 6 minutes we have to start the resuscitative measures. 9 minutes if it still persists, that is the bradycardia still persists, even after 6 minutes of the resuscitative measure, shift the patient to the theater by 9 minutes. Within 12 minutes, we have to start the cesarean section, and 15 minutes, the baby has to be delivered. This is the 3 minutes rule for a prolonged bradycardia if it persists even after 9 minutes with the resuscitative measures. I told you that is the transperineal ultrasound. That is the another new way of assessing the labor progress. So here we are measuring the angle between the symphysis pubis and the leading part of the fetal skull. That is known as the angle of progression, AOP. So it will tell you how much, whether the, what is the, it will clearly rule out the caput and the caput. So we can clearly assess what is the station of the fetal head in relation to the ischial spine, whether we can apply the instrumental delivery, how much time we can give, all these things we can apply. So there are certain other few things in the first stage of labor. When the patient is having fever, there is more than one fever spike, we have to do the C-reactive protein and throttle gown. Then we have to start the antibiotics, and it has to be continue till delivery. Take a swab swab from the placental site after delivery and send it for culture and sensitivity. Continue antibiotic if persistent fever and warm and foul smelling loci after delivery. Inform the neonatologist. Otherwise, there is no, I told you earlier, there is no routine use of antibiotics after ARM and no need. But if the after ARM, if the labor delays after 18 hours, if the fever spikes appears, we have to start. These are the interventions with less beneficial in the first stage of labor. Enema use is debatable nowadays. Some people are saying the solid motion is better to remove than the liquid stools. Perineal shaving is of less use. It can introduce infection. Routine bladder catheterization has to be avoided, no use. And routine antibiotics and ointments after delivery, especially ointments episiotomy, it's of no use. Antispasmodics like drotaverine and Buscopan is of no use. So the first stage monitoring is over. Now the second stage. The second stage has got two stages. There is a passive second stage that is known as the pelvic phase of second stage, and the active second stage, that is the perineal phase of the second stage. So in the passive phase, cervix is fully dilated in the absence of involuntary expulsive contraction. So patient doesn't have any bearing down contraction. But in the active, so that stage, we should not advise the patient to bear down. So we can give, the patient can be in the left lateral position, continue the epidural analgesia, whatever patient is having. But in the active second stage, you can see the fetal scalp visible with expulsive contractions. So that time only you have to encourage the patient for pushing. So that time, if the bladder is full, you have to empty the bladder. You can encourage the patient can go to the washroom and she can pass, or if not possible, we can do the catheterization, NELCAT, and continuous CTG or the intermittent fetal heart auscultation in between contraction for 1 minute. We have to see to find out any deceleration. So continue the oxytocin in the same dose and do not stop the epidural analgesia once the patient reaches second stage. It has to be continued. So these are the when to intervene in active phase. Without epidural analgesia, we can allow for a primary for 2 hours in the second stage and 1 hour for a multi. With epidural, we can add 1 more hour. So we can give 3 hours for a primary with epidural and 2 hours for a multi with epidural. If everything is fine, maternal condition is fine and the fetal heart rate is okay. So usually the second stage does not exceed 3 hours in a primary and 2 hours in a multi. So in the second stage also, just like the first stage, patient can adopt any position of choice. Patient can stand, patient can, that is the squatting position, everything is okay. But when we need to do any interventions like episiotomy, ideally patient should be in the semi-recumbent position. So not always in the dorsal position or the lithotomy position. Another most important thing nowadays in the second stage of labor, that is to decrease the episiotomy, is the perineal massage and the warm towel compression to reduce the perineal trauma. So the perineal massage, I will explain how to do the perineal massage and the warm towel compression, so that the we have to, so whenever before applying the warm towel compression, that warm hot compression, we have to check the temperature of the warm water also, the towel also, it has to be, it should not be too hot. And the hands-on technique during the second stage to prevent the sudden extension of the head and thereby the perineal tears. No routine episiotomy in modern obstetrics. It's a selective episiotomy. Whenever we are putting the episiotomy, it should be the mediolateral episiotomy, 60-degree angle from the midline, it has to be put. So, and in the second stage, no manual fundal pressure also. Routinely don't allow for the manual fundal. So these are the few things we have to know: fundal pressure, no routine episiotomy, it's only a selective episiotomy, hands-on technique to prevent the sudden extension, expulsion of the fetal head, perineal massage, and the warm towel compression, any position of the choice. and the perineal massage. So we can advise during the antenatal class, the patient can start at 35 weeks of gestation once or twice. Patient can do it by herself with some lubricant she can use. Intrapartum, we can do the perineal massage. So insert the finger with lubricant, insert into the vagina, and we have to sweep our fingers from side to side and depress in the middle. And this depression has to be continued for 45 seconds to 60 seconds. In between, 1 or 2, every 2 to 3 times we can repeat in 10 minutes. So that will prevent the perineal trauma and the need for the episiotomy. It will decrease the need for episiotomy. So it's a good thing, perineal massage. Now, after the second stage, the baby is delivered and we are coming to the third stage of labor. It's very, very important to prevent the postpartum hemorrhage. So always do, whether it's a cesarean section or normal delivery, active management of third stage of labor is done. So in Kerala, we are following the KFO, Kerala Federation of Obstetrics and Gynecology regime. That is, within 1 minute of delivery of the fetus, we are giving 5 units of oxytocin IV plus 10 units of oxytocin IM, and 20 units we are adding in 500 ml normal saline and giving at the rate of 60 drops per minute. With this regime, there is a drastic reduction in the PPH. So touch wood in Kerala. So we are not seeing much of the referred cases. And so this is the protocol. So almost all the gynecologists and the obstetrician in Kerala are following this active management of third stage of labor. We are promoting this one. And the next stage is the delayed cord clamping. So we have to wait for 1 minute before clamping the cord. That is to improve the neonatal nutrition and to prevent neonatal anemia. So the controlled contraction for the placental delivery, only when the uterus is contracted, then only we have to do the placental delivery. And soon after delivery of the, before clamping the, cutting the cord, we can put the baby on the maternal abdomen. So early skin to skin contact, and at the same time, baby can start feeding, promote the breastfeeding. And the last is the fourth stage of labor. This is to, after the delivery, we have to monitor the patient for 2 hours in the labor room. That is known as the fourth stage of labor. That is the time most of the complication arises. We have seen most of the complications. So it's very important monitoring in the fourth stage. This is a golden hour. So here in the 2 hours after delivery, every half an hour we have to monitor the maternal pulse, maternal blood pressure, and see whether the uterus is contracted and it's in the midline. And while assessing the uterine contraction, also assess the vaginal bleeding. While pressing the uterus periabdominally, there should not be any excess bleeding. So these are the things we are monitoring every half an hourly to see, to early diagnose PPH. So this is the, in nutshell, this is the ARCP approach for the intrapartum care. Assess the well-being of the woman and her baby, and assess the progress of labor. Then whatever we are assessing, we have to record that, document the labor observations in the partogram. Check reference threshold, that is in the new labor care gate. Compare the labor observations with the alert column and the plan shared decision making. Whatever decision and interventions are required in consultation with the patient, and it has to be documented. In conclusion, intrapartum care has undergone paradigm shift. No contemporary criteria for normal or abnormal duration of the latent phase. We are not including the latent phase. Only the active phase we are including. That time only we have to keep the patient in the labor room. Cervical dilatation and descent varies in each and every woman. Consider the woman's choice and her emotional state while going for any intervention. All women should have a positive childbirth experience and respectful maternity care. That should be our motto. Thank you, everyone.
Thank you so much, ma'am. Thank you so much for such a elaborate and wonderful session. I would request Chandrika madam to conclude this session, say a few words about this, ma'am.
Excuse me, can I just ask a question?
Yes, sir. Yes, sir.
Of course.
Before the concluding remarks?
Yes, sir. Sure, sure.
Yeah. Madam Menon, I really enjoyed your talk, and it was nice that you are, as expert obstetricians, we make every effort to prevent complications. But the thing is, I just wanted to ask you to make the obstetric, the delivery part more pleasant. Are there labor rooms where they play music, have fragrance, so that it becomes more soothing part for that lady who is in labor? I understand the whole focus, there's a lot of pain and other things, but will such a thing soothe her and make the experience more worthwhile? This is just a thought which I just since.
Do you mean aromatherapy? Aromatherapy?
Aromatherapy, yes.
So we have seen
Music,
musical
aromatherapy together.
Yeah, musical therapy. So the light music and so instrumental music. So we can play. So I never heard about the aromatherapy because it's in most of the labor rooms are air conditioned. Sometimes it can produce some allergy too. We don't know. Maybe many patients are there. So that is nowhere it is advised that I have cross-checked the NICE guidelines and the WHO guidelines, and I have gone through many and the up-to-date also. ACOG also they have not mentioned about the aromatherapy, but musical therapy somewhere I have seen.
Okay.
Maybe maybe sometimes due to the allergy to some patients could be the reason.
But music probably would be a universal thing that can be played. It's simple but soothing.
Yes. Soothing. Yeah. Okay.
Excellent talk, madam. I really enjoyed.
Thank you.
May I request Chandrika madam to say a few words?
Ma'am, you are on mute. Chandrika ma'am, you are on mute.
Yes, is it audible now?
Yes.
Yeah. So, Dr. Bindu, we enjoyed your talk and you were beautifully narrating the whole story of how the baby is coming out and what are the events like that. And we enjoyed. And it was a very beautiful presentation. And also, one more thing I wanted to add is this immediate postnatal period is also equally important. And also, we may come across with a lot of problems like PPH and amniotic fluid embolism sometimes, and so many problems like that we can come across with. So that we have to have one thing we should have all arrangements for availability of blood and also trained personnel inside the labor room. That is very important. ORRT team, that is also very important inside the labor room, and who had, of course, this training in EMOCAL training, that is emergency obstetric care and life support for the pregnant lady, and also this emergency drugs and emergency, if at all we need emergency intubation and resuscitation of the patient, like that. So all these things should be kept ready in every labor room. That is a must. So that is also equally important when we are talking about safe motherhood.
Yes.
And so that is the only thing. And also in the third stage, when the patient every half an hour or we are checking for pulse, respiration, BP, and whether the uterus is contracted or not, and whether there is bleeding or not, like that we are checking. But what I have seen is people, they will go to the patient and they will just see from front. They will see the pad and also they will palpate. Of course, they palpate the uterus as well, but they never see the behind the buttock, because that is the area where, if at all there is a bleeding, the blood is collected behind the buttock only. So most of us, we miss. And sometimes we have seen patients who are soaked in blood with PPH. From when you are seeing the patient from above, there may not be much bleeding as well. So that part also is, it is a very important aspect I would like to tell you, because bleeding most often that will be draining towards the back of the lady. and she will be in a pool of blood, which may not, if you are not that careful about it, that will be leading to a lot of problem. So that is also important aspect I wanted to tell you. And thank you so much. And it was a very beautiful presentation, and we enjoyed your presentation as well. Thank you, madam.
Thank you, Chandrika madam, for the enlightening the salient points. Yeah, we have to check for the under the pad, we have to under the undergarments, we have to check for the blood, any bleeding for the PPH, and also for highlighting the importance of the, just like the shoulder dystocia drill, we have to do the frequently the PPH drill, eclampsia drill, acute collapse drill, all these things we have to, then only all the staff and the other doctors in the labor room will be aware of all these things when there is an emergency comes. So we cannot always expect the normal, joyful childbirth. Sometimes, sometimes
definitely,
it can, if it is, yeah.
The outcome we cannot anticipate.
Cannot assure.
So all
Only
these
after
things should be ready in every labor room.
Yeah, all are expecting a joyful maternity care and the childbirth. Sometimes everything can.
Sometimes we are going away from our expectations.
So, we are especially in the low risk patients, we have seen more chance for the maternal morbidity and mortality, especially in the low risk patients. Thank you, ma'am, Chandrika ma'am. And thank you, Dr. Vaishali, for this opportunity. Once again, all the best. We will support you from our society.
Thank you so much.
All the best.
And I also wanted to tell you what a fantastic talk you have given. I'm sure all the young attendees who have logged in today are going to benefit. And everything that you said, was so perfect. Even all over again, labor from you at each and every step, especially the CAFOG, the system that you're following, the CAFOG system for management of third stage of labor. That is wonderful. I think we should start implementing. I am going to start using it from today itself. And if it has been times tested by Kerala OBGYN Society, I'm sure it is going to be good and reduce
there is a drastic reduction in PPH.
Yeah, so
I would like
new thing. Yes, Kalyani.
if I am permitted.
Of course, please. Go ahead.
Yes, madam, it was absolutely delightful to listen to your talk.
Thank you, ma'am.
Good revision of the 4 days, and really loved it the way you have put presentation. It's so perfect. I mean, today also I was absolutely, I did not think of it once also. I have taken the screenshots of your presentation once again, and I would request that this has to be present. So who are into the education, it was that beautiful, madam. The have mentioned even under epidural analgesia, under epidural, how to monitor the patient. It is so very important. So many times we give the epidural and we just leave it. Okay, this is going to happen. And the time criteria given is so perfectly narrated. I really loved it. Really loved the presentations both. Please much to make me a part of this whole session. It was an eye-opener for me after so many. Wonderful to listen to all you seniors, Dr. Chandrika madam. Your inputs are also so very important. Thank you, Vaishali, to bring me to this forum. I'm really grateful and thankful to you.
Thank you, Kalyani, for being here. And Chandrika ma'am, what you said, the practical point is important. We're all to check for bleeding, and we may miss PPH if we don't check below the patient's buttocks. So such an important point. So a beautiful talk, ma'am.
Thank you.
Thank you so much, ma'am. Yes, ma'am. Thank you, ma'am. I really loved one point, madam, mentioning about the transperineal ultrasound, which is less touched, and like very few people are aware about that. Being a fetal medicine person, I picked up that point, and because doing pervaginal examination repeatedly may cause infections and also the pain and discomfort to the patient. So role of transperineal ultrasound nowadays is really important, and many people are doing that. And also, as Sanjeev Kut sir said about the aromatherapy and music therapy, many private hospitals are including that in their delivery norms, and people, because it's like fancy and like, you know, the acceptance is very much. And also about this birth companion, I think the partner husbands are more involved into this, and the patients are like quite calm and confident during the time of delivery. So very wonderful.
Ma'am, such a wonderful talk yours was. So I will try to get a link for this webinar, and I will post it on the our WhatsApp group also as soon as I get the link.
Thank you.
Thank you so much.
वैशाली छान झाले दोन्ही लेक्चर एकदम सुंदर.
Madam,
eye opener.
Yeah, it was a big learning for me personally, especially the animated shoulder dystocia that you showed, and especially now with Madam also talking about the pleasant experience in labor. It was a big learning experience for me personally. So thank you for including me in this webinar. It was a wonderful, both wonderful talks and a great learning opportunity. And my best wishes.
Anybody doesn't wait for the shoulder dystocia to obstruct. Beforehand, they take the decision for the Caesar.
Yeah.
I understand.
So I would like to thank everyone for being here, and we are truly heartfelt gratitude from bottom of my heart for your esteemed presence. Sarina ma'am, Sanjeev Kur sir, our guest of honors, Dr. Hema, Dr. Rashmi, Dr. Bindu, ma'am, fantastic talk, Dr. Chandrika ma'am, Dr. Kalyani, and of course our very own POGs, Dr. Aarti Nimkar, Dr. Meenakshi, Dr. Amol, and our young MOC, Dr. Shubhangi, who's a fetal medicine expert, but she was here today for obstetric topic, and Dr. Sandhya. Of course, thank you to BSV for being our academic partners, and thank you everyone for being here. Thank you very much.
Thank you so much, ma'am. I now, as all of us know, that Madam is contesting for Vice President FOGSI West Zone post elections. So we solicit everyone's blessings for Madam. Thank you.
Thank you everyone for that
Thank
wonderful.
you, Dr. Shubhangi. You coordinated very well.
Thank you so
Got
much.
all of us together in time. Great.
Thank you, sir. Thank you.
Thank you.
Thank you, Shubhangi.
Thank you. Thank you, ma'am.
Thank you, Vaishali.
Thank you.